Assalamu alaikum wa rahmatullah. Medical students and medicine fans all around the world, this is Abdurrahman al-Tarazi, a 6th-year medical student from the Hashemite University in Jordan. And you're looking at the first video of a review series for most of the basic science lectures to help the doctors and the final year and all medical students who want to refresh their basic science, and also to those who are aiming to start step 1 USMLE preparation. So this review series will help you, inshallah, so keep up with it. Okay, now we will start Anatomy will be the first subject to discuss here, because it's easily forgotten, and I saw a big deficit actually in the knowledge of anatomy, especially in the clinical students. So we will start by the mediastinum anatomy and the heart and the major vessels anatomy, and they will move on to other parts of anatomy in next videos, inshallah. Okay, so we see here the mediastinum. The mediastinum is divided, as we all know, into the superior and the inferior parts, superior mediastinum and the inferior mediastinum. Now, the line that separates both of them is called, it starts from the sternal angle to the lower border of the T4 vertebrae. So it starts from the sternal angle, or it has another name which is Lewis angle, and it separates the superior from the inferior mediastinum. Now, the clinically important part here is that we have to know each part of the mediastinum, what does it contain. So we see here the anterior mediastinum, mainly it contains ligaments, and it's not that clinically important. The middle mediastinum contains the heart, obviously, and the beginnings of the major vessels, the pulmonary, the aorta, and the pulmonary trunk. And in the posterior mediastinum, we will discuss it later, but we have also major vessels and some other nerves. Now, in the superior mediastinum, we have a lot of things. Let's see the next slide. The superior mediastinum, as we see here, contains first of all the thymus, and this is very important to know, because you can be asked about this in your step 1 exam or in your clinical, in your college exams in a lot of ways. For example, it can you can see a case about DeGeorge syndrome, or one of the 22q11 deletion syndrome, where you have thymus hypoplasia or the thymus is absent, and they can simply ask you, where should we look for the absent organ or for the abnormal organ, and you should answer in the superior mediastinum. So this is how they're going to link your clinical and basic science informations together. Other than the thymus, we have major vessels. We do have the brachiocephalic, the left and the right brachiocephalic veins, and when they come up together, they form the superior vena cava. We also have the major vessels. We have deeper to the veins. We have the subclavian vessels. We have the subclavian, the right and the left. We also have the arch of aorta, as we see here, arch of aorta and its major branches, the right common carotid, and the right and the left common carotid. We also have deeper to the veins the arch of aorta. As we see here, we have the arch of aorta and its major branches: the right brachiocephalic artery, the left subclavian, and the left common carotid arteries. Okay. Next slide here, we see the posterior compartment. Now I have to emphasize this, to emphasize something on this slide. I believe that anatomy to be understood well, and to study it in a way that you don't forget it, you have to memorize the picture. You don't have to memorize things. So for example, when you see this slide or any other slide like this, where you see a lot of words and sentences, and you see a picture, please focus on the picture. Try to copy this picture into your mind. This is how you're going to answer your question. This is how you're going to get an A+ in your anatomy subject. So in this picture, forget what is written here. In this picture, we see the contents of the posterior mediastinum. We see the descending aorta. Of course, the arch is part of the superior mediastinum, but the descending aorta is part of the posterior mediastinum. We have the esophagus. We have the trachea and its divisions, and we do have thoracic duct. It's not in this picture, but it's mentioned here. We do have the thoracic duct. We have the sorry for this. We have the thoracic duct. It's not apparent in this picture, but we have the thoracic duct that drains into the left the junction between the left internal jugular vein and left subclavian veins. And we do have other things. I mentioned the most important things, and this picture shows you the most important things for you to remember, because as I mentioned earlier, this review series will not contain everything you need to know. It will contain the most important things. Okay. Next slide, we will talk about the heart, the main anatomy of the heart. We will talk about the heart and the major blood vessels, and how is okay. In the next bunch of slides, we will talk about the heart and the major blood vessels. As we see, this picture, I believe this is very high yield picture for you to know for your step 1 exams, for your college exam. This is very important for you to bear in mind. The normal anatomy and the normal position actually of the heart in the thorax. As we see, the heart is in the middle of the thorax, in the middle mediastinum, and it's slightly more tilted to the left. Very important to know the borders and the surfaces of the heart and their main components. Let's start with the very prominent here, the right border. The right border of the heart is composed mainly of the right atrium. And to a lesser extent, we have some participation of the right ventricle, but mainly I need you to remember that the right atrium make the right border. The left border of the hand, on the left border of the heart, sorry, on the other hand, makes the mainly made by the left ventricle, and we do have some little participation of the left auricle. Sorry about this. We do have some little participation from the left auricle of the left atria. So mainly left border is left ventricle. This is straightforward. The inferior border is mainly made by the right atria. The inferior border is mainly made by the ventricles, the right and the left ventricles together. Now we have to remember that the apex of the heart, which is normally on the left, the apex of the heart is part of the left ventricle. So the apex of the heart is part of the left ventricle, and on physical exam you have to remember that the apex of the heart is positioned in the left fifth intercostal space, midclavicular line, as we see here. So when you're doing any physical exam, your doctor will ask you when you're palpating the apex beat, where is the apex beat normally positioned? You will tell him loudly, left fifth intercostal space, midclavicular line. This is very important to bear in mind. Other things that are very important, which is the surfaces of the heart. The surfaces of the heart are important because they can ask you about it by a clinical vignette talking about someone who has been stabbed in his chest, and they simply ask you what is the affected part or what is the damaged part. The anterior surface of the heart, and this is very important, the anterior surface of the heart is mainly made by the right atria and the right ventricle, and mainly the right ventricle. Now we do have some participation of the left ventricle, as it, you see this picture, the right atria and the right ventricle. We do have some little participation of the left ventricle, but if anyone gets stabbed in his chest anteriorly, mostly it's his right ventricle that is damaged. If there is any part of the heart that is damaged, mostly it's the right ventricle, because it's the main component of the anterior surface of the heart. Now the inferior surface of the heart, it's not prominent here, but the inferior surface of the heart is composed of both ventricles, but mainly the left ventricle. So it's the opposite of the anterior. The inferior surface is composed by the left ventricle mainly, and we do have, like, it's 2/3 the left ventricle and 1/3 for the right ventricle. Okay, this is why I need you to know. Now this picture shows a very important surgical association. We have something called the transverse sinus in the heart, or in the superior mediastinum, actually, to be more precise. In the superior mediastinum we have what is called the transverse sinus. Now this transverse sinus is situated as this finger is in the transverse sinus, so it's anterior to the superior vena cava and posterior to those two major vessels, the aorta and the pulmonary trunk. Now why is this important? Because when you're doing any surgeries in the aorta or in the pulmonary trunk and you want to ligate the artery, so this is where you're going to position your finger in order to take good control of the aorta. Okay. This slide shows us the coronary circulation. Now please remember each major vessel in this slide, because in your step 1 exam and in your college exam you're going to be asked about this. So let's start by the right coronary circulation, by the right main coronary. Now as you notice, the two coronaries takes origin from the ascending part of the aorta. We have the ascending, the arch of aorta, and then the descending part. The ascending part, both coronary takes origin from here. The right coronary starts and walks in the coronary groove and gives small branches to the right atria to supply the SA and the AV node. And here is an important association. Now I just mentioned that the right coronary supplies the SA node, and we all know that the SA node gives the heart its basic rhythm, and it gives it the heart rate. So if you have a ischemia or if you have infarction in the right coronary, you may see bradycardia, because the SA node is ischemic. So if you're faced with a question where you have a infarction MI patient or angina patient and he's bradycardic, think about right coronary pathology. Okay, so we'll move on, and here we have small vessels supplying the right ventricle. The major vessel that I want you to remember here is the marginal branch that is given at the right border of the heart. So at the right border of the heart we have from the right coronary we have the marginal branch. After the marginal branch, the right coronary continues in the coronary grooves until it reaches the interventricular groove, the posterior interventricular groove, and it gives the posterior interventricular branch. Going to the left coronary is smaller in most people, and it's not the dominant artery. The dominant artery is the right coronary in most people. So the left coronary divides into the circumflex or the left circumflex branch and the anterior interventricular branch. Now from the anterior interventricular branch we have an artery, this is it, called the left anterior descending artery. Left anterior descending artery. Let me write this for you. And why am I highlighting this? Because this branch is the most common vessel to be blocked in coronary syndromes. The angina and all the MI and all this theme of pathology. The most common vessel to be blocked is the left anterior descending branch. Okay, so the circumflex will continue in the coronary groove, and it will supply the left ventricle and the left atria, continue to anastomose with the right coronary. Now we have another concept, which is the dominant circulation. Now we have this branch called the posterior interventricular branch. Now depending on which vessel gives this branch, it is the dominant vessel. So this branch is important to anatomists, because if the right coronary gives the posterior interventricular branch, which is the case in almost 90% of people, the right coronary is said to be dominant. So this patient is he has a right coronary dominant circulation. If the left ventricle, if the left coronary by the circumflex branch, if it gives the posterior interventricular branch, which is the case in approximately 5% of the people, then it's you're said to have a left dominant circulation. Now in 5% or less of people in the world, we have what is called the co-dominant circulation, which means that both the right coronary and the left coronary participate in the posterior interventricular branch. So we have to know this, because you may be faced up with a question that tells you that the posterior interventricular branch is emerging from the circumflex, and then he asks you about the type of the. Bear in mind, especially if you're step 1 students, or if you want to prepare for step 1 in your okay. Now this picture is very, very important. We have to bear in mind how is the relation of the major vessels when they take origin from the heart. We have here the ascending aorta, we have here the superior vena cava, and here is the pulmonary trunk. So in the middle we have the aorta, and to the right we have the superior vena cava, and to the left we have the pulmonary trunk. We have to bear this in mind. Now you know that this is the ligamentum arteriosum, and this is the remnant of the PDA, of the ductus arteriosus, that gives you the shunt of the blood from the right to the left circulation in your intrauterine life, and this is the remnant of it, the adult remnant of it. Now, very important and clinically important information here. The vagus nerves gives a branch called the recurrent laryngeal nerve. This is the branch. This is the branch. It takes origin. It starts from here on the left, and it starts from here on the right. And this is very important to differentiate between the origin of the right and the left recurrent laryngeal nerves. This is the left, and this is the right. As you notice, the right takes origin from the subclavian vein, from the subclavian artery. Sorry, it takes origin under the subclavian artery. The left, however, takes origin under the arch of aorta. So the left is basically slightly longer than the right, and they both run between the trachea and the esophagus. They both run between the trachea and esophagus. So if you have any injury in this area between the trachea and esophagus, and you're faced with a patient who's having dysarthria, who cannot speak, think of recurrent laryngeal nerve, because we will see this later. The recurrent laryngeal nerves, they give most of the vocal cord muscles. Most of them, they are supplied by the right and the left recurrent laryngeal nerves. Okay. This picture is also important. We see here the conduction system of the heart and the SA and the AV node. First of all, I want to drag your attention to the position of the SA node. Very important, and I assure you that you will see this picture in a lot of in a lot of question banks. Where is the site of the SA node? Where is the exact site? It's situated in the right atria, in the right atria between the opening of the superior and the inferior vena cava, closer to the superior vena cava. Very clear on this picture. Please remember the picture. Closer to the superior vena cava. The AV node, however, is situated in the interatrial wall. So it's in the interatrial, in the right atria, in the interatrial wall, exactly. This is called the AV bundle. The AV bundle is situated in the interventricular wall. maybe it's not 100% prominent here, but it's situated in the the AV bundle is situated, not the AV node, the AV bundle is situated in the interventricular wall. And we do have here the Purkinje fibers. As you know, this is a fast conducting fibers to enable all the ventricles to contract with each other to give them 100% efficacy and a very powerful stroke volume. And we do have the right bundle and the left bundle branches, and it's very important to know the ECG changes with the right and with the left bundle branches. Okay, carotid sheath. Let's see this picture. Oh, okay. Let's see this. Let's first know what is carotid sheath and what does it contain. Carotid sheath is formed by all three layers of deep fascia. Contains the carotid artery, the internal, not the external, the internal jugular vein, and the vagus nerve. So basically, three things, easy to remember: vagus nerve, internal jugular, and carotid artery, the common carotid, and then the internal carotid artery. This picture shows you the relation of the carotid sheath. This is the carotid sheath, very clear. This is the carotid sheath, and this is a cut section. We cut the sternocleidomastoid muscle. This is very important muscle in the neck. Posterior to it, we have the carotid sheath. This is the omohyoid muscle. It should be like this. Anterior also to the jugular, to the carotid sheath, which contain the internal jugular vein, the carotid arteries, and the vagus nerve. So posterior to this sheath, we have the sympathetic trunk. Anterior to it, we have the both muscles that I've just mentioned, which are the sternocleidomastoid and the omohyoid muscles. We have to remember this, and we have to bear in mind this picture, the relationship between the major vessels and the carotid sheath and the muscles that I've just mentioned. In this slide, this is the very simple slide actually. I just wanted to remind you that we have here what is called the brachiocephalic artery. The right circulation is slightly different from the left circulation. In which way? We have this brachiocephalic artery that takes origin, the first artery that takes origin from the arch of aorta, and it divides into the common carotid. This is the common carotid, and this is the subclavian artery. Now on the left side, this is not the case. We have here the common carotid artery that takes origin directly from the arch of aorta, and this is the right common carotid actually. And then this is the left common carotid, and then we have the left subclavian artery that also takes origin directly from the arch of aorta. So we don't have a left brachiocephalic artery. We have only one brachiocephalic artery on the right that divides into the common carotid, right common carotid, and the right brachiocephalic artery. Now this artery, thyroid EMA artery, I will talk about the thyroid circulation in the next videos, but I just wanted you to remember that this artery is not found in all human beings. So there's a variant, anatomical variant, in which we don't have this artery, and it's not essential for the thyroid gland supply. And as you notice, it also takes origin from the arch of aorta directly, if it was found. In this slide, we have the subclavian artery. Now, I know that this is a complicated slide, and I don't want you to remember all the branches of the subclavian artery. But here we have a very important branch, which is called the thyrocervical trunk. This is the thyrocervical trunk. It's a short branch that divides into a lot of vessels, including the transverse cervical artery, the suprascapular artery, and the inferior thyroid artery. From the inferior thyroid, we may have the ascending cervical artery. So three branches that takes origin from the thyrocervical trunk. I'm gonna repeat it again. Suprascapular, this is it, suprascapular, transverse cervical. Transverse cervical runs on the sternocleidomastoid horizontally, and the inferior thyroid artery. This is the vertebral artery. This is the vertebral artery. I'm going to show you another picture, but it's very important to remember this, because a lot of students mentioned that in their exams, in their step 1 exams, they're faced with an angiography and they're asked about one of the branches of the vertebral artery. So you have to know the major branches which I have just mentioned to you. Okay, this slide is also very important to remember. This shows us the relation between the scalene muscles, the different scalene muscles, and the subclavian artery and vein and the inferior trunk of the brachial plexus, actually. So as you notice here, we have this anterior scalene. This anterior scalene muscle is anterior to the subclavian artery, but posterior is anterior to the subclavian artery, but posterior to the subclavian vein. So it's different. Very clear image. Please remember all the details in this picture. The scalenus minimus is posterior to the artery. So scalenus anterior is anterior, and scalenus minimus is posterior. Also, the scalenus medius or middle scalene muscle is also posterior to the artery. So as you notice, we have this arrangement: vein, scalenus anterior scalene, artery, scalenus minimus, inferior trunk, middle scalene. Okay. Next slides shows us the pathway of the subclavian artery and how it changes to the axillary and then the brachial artery. Now you have to know that the subclavian artery changes its name to the axillary artery under or at the outer border of the clavicle. This is the clavicle. This is the outer border of it. After the outer border of the clavicle bone, we can call this vessel the axillary artery. Now at the lower border of the teres major, you notice this is the teres major muscle. At the lower border of it, this artery is called now the brachial artery, and as you notice, it goes medial to the biceps. This is very important, medial to the biceps muscle. At the neck of the radius, this is the radius bone, and this is the neck of the radius. And as you notice here, at the neck of the radius, the brachial artery divides into two arteries: radial artery and ulnar artery. And you know also the radial is medial to is lateral to the ulna. What I want you to remember is the relation between the insertion. This is the insertion of the biceps and the brachial artery. The brachial artery is medial to the insertion. This is important, especially when you're palpating the brachial pulse. When you're palpating the brachial pulse, you should put your fingers slightly medially, as you notice here. So if you see a doctor, and this is a very common mistake actually, they put their fingers here or there, lateral in the lateral elbow, and they say that, oh, I'm not palpating the brachial pulse. Actually, the brachial pulse is medial to the insertion of the biceps, and it's in the medial side of the elbow joint. Okay, this is the superficial part or the superficial component of the vein system of the upper limb. Now the venous system is divided into superficial and deep systems. This is not very important to know. What I want you to remember is that the site and the names of the important vessels. We have here what is called the cephalic veins. Now all the forearm veins, we have a lot of small veins, but what I want you to remember is that we have all the veins, they drain into two major vessels: the basalic vein, this is it, and the cephalic vein. The cephalic vein is lateral to the basalic vein. It's in the lateral arm, and the basalic vein is in the medial arm, and actually here it pierces the fascia to continue as the axillary vein. So the basalic vein is the direct continuation of it is the axillary vein. This is very important to remember. Okay, here we see the median cubital vein, the medial cubital vein. Now to give you an idea about how this connection is very important, it links the cephalic with the basalic vein. So it links two major vessels together. The median cubital vein is important, and I've highlighted it because it's the site of major IV fluids in the elbow and the forearm, and the major site of when you draw blood, when you draw venous blood from the elbow, and it's a very common site for this procedure. You are taking blood from the median cubital vein. It's very prominent, especially if you see a thin male. You can see the median cubital vein and you can palpate it actually. This picture shows us the how the basalic vein continues After it pierces the fascia, continues as the axillary vein. Now this picture is not very accurate, but the anatomists say that under the lower border of pectoralis major, this is the pectoralis major muscle, at the lower, after the lower border of it, so from here on you can call it the axillary vein. You know, so from the lower border of the pectoralis major, after it you can call this vein the axillary vein. Before this it's the basal vein. Not very important, just for you to just put everything in its perspective. Okay, so the axillary vein will continue as the subclavian vein, and it will unite with the internal jugular vein. You see this big vein in the medial side of your neck? This is called the internal jugular vein, and we mentioned it, if you remember, in the carotid sheath, because the internal jugular vein and the carotid arteries and the vagus nerve, they are tied together with something called the carotid sheath. Very important to remember. So this internal jugular vein with the subclavian vein, they form the brachiocephalic, the right brachiocephalic, and we have the left brachiocephalic respectively. So the right and the left brachiocephalic veins, they unite together to form the superior vena cava. So if I asked you how the superior vena cava is formed, or it's formed from which veins, it's formed from two veins, right and left brachiocephalic veins. Now I have to mention here that at this side, the junction between the internal jugular vein and the subclavian vein, the left one actually, we have a very important structure called the thoracic duct that drains into this place. Now I will explain all the lymph node drainage in details, but we have to remember that the thoracic duct drains all the lymph in the body except the right side of your face and the right upper limb. So the right upper limb and the right side of your face are not drained, not the face actually, or the head to be more accurate. The right side of your head and the right upper limb, they're drained by other duct. We'll talk about it. All the other parts of your body are drained by the thoracic duct into this place, this junction. Important. Okay. Now we've talked about the mediastinum. Let's go below these structures to talk about the abdomen. We have a lot of important things here. Here we can see how the descending aorta continued as the abdominal aorta after it passed through this opening in the diaphragm. Now it's called the abdominal aorta. Now abdominal aorta at the level of L4, it divides into two structures. It divides into right and left common iliac arteries. The common iliac will divide into internal and external iliac. We will talk about this later on. But the abdominal aorta divides at the level of L4. Very important to remember. Before it divides, it gives a lot of important branches that supply the GI tract. Now another important thing to talk about here, which is the opening of the diaphragm. We have three main openings, only three openings actually of the diaphragm. The first one is the inferior vena cava opening, which is the highest one. It occurs at the level of T8, thoracic vertebra 8. So we have to remember these things. When I write something, please, you can write it on, or if you remember it, refresh it in your mind. But it's very important to remember that the inferior vena cava opening is at the level of T8. Now below this, we have this opening, which is the esophagus opening, at the level of T10 vertebra. T10. And the lowest opening is this opening, which is for the abdominal aorta, and it occurs at the level of T12. T12. Sorry for my drawing, I know it's not very accurate. Okay, T12 vertebra. Okay, so this is the important things from this picture. We will get back to this. Okay, I forgot something. With the esophagus, we have the vagus nerve. So we know that the vagus nerve supplies the GI tract and supplies parasympathetic nerve fiber to the viscera, and it enters the abdomen through the T10 opening with the esophagus. Okay, the first important branch, which is the celiac trunk. The celiac trunk. We have to remember all the branches of the celiac trunk. First branch The first branch is the splenic artery. Now the splenic artery supplies the spleen, as the name implies, and it also gives this important branches, which is the short gastric arteries. It supplies the fundus and the upper parts of the stomach. We will talk about the stomach circulation in details, but we have to remember that the short gastric artery takes origin from the splenic artery. After the splenic artery, we have the left gastric artery. You will see another picture of it. The left gastric artery. This is the left gastric artery. This is it, the left gastric artery, which takes origin from the splenic, as you notice here. This is it, from the celiac trunk. Okay. After the left gastric artery, we have here the common hepatic artery. This is it, the common hepatic artery. Don't get lost with all the branches. We will go them one by one. So this is the common hepatic artery. The common hepatic artery gives us the right gastric artery. Where is the right gastric? This is the right gastric. So this is the left gastric artery from the celiac trunk directly. From the common hepatic, we have the right gastric artery, and they anastomose with each other. Now we have to know that the stomach is really very it has a very rich supply of blood. This picture shows us the common hepatic artery branches. Now, as you notice here, this is the common hepatic artery. Remember the three branches of the celiac trunk, which are the splenic, the left gastric, and the common hepatic. Now, after this branch, the gastroduodenal artery, the common hepatic artery changes its name to the proper hepatic artery. Proper hepatic artery divides into right and left hepatic arteries. Now we have to remember that the cystic artery, this artery, the cystic artery, takes origin from the right hepatic artery. Now you're looking at a triangle called the Carotid triangle. This is important to remember, especially for those who are interested in surgery. This Carotid triangle is composed of three parts: the common hepatic duct, the bile duct, and the inferior border of the liver. Now, why this is important? The cystic artery, this picture is not very accurate. The cystic artery, mostly it lies in the Carotid triangle. So when you see this triangle, you pay attention so that you don't injure this artery, and it will cause you a big complication, and your cholecystectomy surgery will be prolonged, and it will be complicated. So it helps you to identify the cystic artery and to stay away from it. Okay. Thank you for your attention. I'm sorry for any mistakes, and please send me your feedback. I will put my email in the description box, and hit the like and subscribe button, because a lot of good materials inshallah will be coming more and more on this channel. Thank you.